Meet Harold, 71 years old, a type 2 diabetic, found at home confused and barely responsive after days of slipping downhill. His skin tense when you pinch it, his mouth is parched, and he is disoriented. His glucose is not 600, it is 1080. And here is what makes this different. His ketones are negative, and his blood is not acidic. This is not diabetic ketoacidosis. This is the hyperosmolar hygrosemic state HHS, and it is its own emergency. The instinct might be to crash that enormous sugar down fast with insulin. Resist it. In this condition, the sugar is not the first target, and bringing it down too quickly can swell his brain. One patient, 6 decisions. Let's take them in order. Step 1. Recognize the cues. Start in the nurse's notes. An older diabetic, declining for days, now confused, profoundly dry, with a staggeringly high blood sugar. Your task is to gather the findings and, just as importantly, to notice what is missing. Because the absence of certain signs is what tells you which emergency this is. So move through every tab, the vitals, the labs, the orders, the history, and pick out the cues. Some of the most important findings here are the ones that are normal. Take it in. Open the vital signs tab. His heart rate is 118 up, and his temperature is 38.4, a low-grade fever that hints at an infection underneath. His blood pressure is 98/56 on the low side from dehydration. And notice 2 things carefully. His breathing is 20, normal. There is no deep Kussmaul pattern here because he is not acidotic, but his neurological status is not normal. He is confused, responding only to voice. That altered mental status is a central cue because, in this condition, how awake he is tracks how concentrated his blood has become. Now the labs tab, and this is where the diagnosis is made, as much by what is absent as by what is present. His glucose is 1080, extraordinarily high. His serum osmolality is 372, meaning his blood has become dangerously concentrated. But now the discriminators. His ketones are small to negative, and his pH is 7.32, only barely low. There is no significant ketosis, and no real acidosis. That combination, an enormous glucose and osmolality without ketoacidosis, is the signature of the hyperosmolar hyperglycemic state. And his potassium and his blood urea nitrogen are up, marks of the profound dehydration. Now the orders tab, notice what leads it. Isotonic saline ordered for aggressive resuscitation, not a modest maintenance drip. The insulin infusion is ordered, but again with a condition. After fluids are underway and the potassium is adequate, there are cultures and a chest film to hunt for the infection that likely set this off. And there are hourly glucose and neurological checks plus clot prevention because concentrated blood clots easily. The orders are telling you the priorities. Fluids first and hard, insulin second, and find the trigger. Finally, the history tab. He has type 2 diabetes, poorly controlled, and he lives alone, with a recent cough, a clue to a brewing infection. He has high blood pressure and chronic kidney disease, which matter because his kidneys and his heart shape how you give those large volumes of fluid. And he has never had a diabetic emergency before. Together, these tell a story. An older, dry, likely infected patient whose sugar climbed silently over days until his brain began to fail. Here are the cues that count. First, the extreme numbers, a glucose of 1080 and an osmolality of 372, blood turned thick and concentrated. Second, the discriminators, negative ketones and a near normal pH, which tell you this is the hyperosmolar state and not ketoacidosis. Third, the altered mental status, confusion that mirrors just how hyperosmolar he is. And fourth, the signs of a massive fluid deficit, the tenting skin, the low pressure, the high blood urea nitrogen. Put them together and the lesson is clear. This is above all a fluid emergency, and the correction must be slow and careful. Step 2. Analyze the cues. The hardest part of this case is not spotting the high sugar. Anyone can see a glucose over 1000. It is correctly telling this apart from diabetic ketoacidosis, because the two look similar at a glance and are treated with a different emphasis. So take each finding and ask which picture it fits. Does this patient's chart point to ketoacidosis or to the hyperosmolar state? Pay special attention to what is missing. Sort them, and everything points one way. A glucose over 1000 is higher than a typical ketoacidosis. An osmolality of 372 is profound concentration. The altered mental status fits the hyperosmolar picture, where confusion tracks the osmolality. And here are the deciding findings, the ones that are absent. There are no significant ketones, and there is no acidosis, No deep small breathing to blow off acid. Ketoacidosis would have both. Their absence, together with the extreme glucose and osmolality, names this as the hyperosmolar hyperglycemic state. And that diagnosis reshapes your priorities. This is a fluid and osmolality problem first, an insulin problem second. Step 3. Prioritize. Name the one problem and the one first action. And feel the pull of the obvious. His sugar is over 1,000, so surely the priority is insulin, and a big dose, to bring it crashing down. Someone else might reach for bicarbonate for the acid, though there is barely any acid here. And a cautious nurse, seeing his age and his kidneys, might want to go easy on fluids. Each of those is a trap. So ask, what is the largest, most immediate threat? And what single action addresses it without harming him? The priority is his profound hyperosmolar dehydration, and the first action is aggressive fluids, not insulin. Here is why. Patients in this state are often 8 to 10 liters down, a deficit far larger than in ketoacidosis. Simply rehydrating him will begin to lower the glucose and the osmolality on its own. Insulin matters, but it is second, and giving a large bolus to crash the sugar can drop his osmolality too fast and swell his brain. Bicarbonate is pointless, he is not meaningfully acidotic. And restricting fluids out of caution would let the true emergency, the dehydration, kill him. Name it as a fluid emergency, and the first thing you do is pour in saline, carefully but aggressively. Step 4. Generate the solutions. Lay out everything that belongs in the plan. This is select all that apply. Start with the mainstay, aggressive isotonic fluids to replace an enormous deficit. Protect the potassium, checking and replacing it as it falls. Add insulin, but as an infusion, and after fluids are underway, not as a crash bolus. Commit to correcting the glucose and osmolality gradually, not rapidly. And hunt for the precipitant, the infection or event that triggered this, with cultures and imaging. Then the traps, a large insulin bolus to rapidly normalize the sugar, and bicarbonate for an acidosis that is not really there. Gather what saves him, leave the shortcuts behind. Here is the plan. First, aggressive isotonic fluid resuscitation. This is the heart of the treatment, and it alone begins to bring the numbers down. Check and replace the potassium as it drifts lower with treatment. Start a regular insulin infusion, but only once fluids are running and the potassium is adequate, and never as a large upfront bolus. Correct the glucose and the osmolality slowly, adding dextrose as the glucose falls toward 250 to 300, so the drop stays gentle. And find and treat the precipitant, the pneumonia or urinary infection that likely lit the fuse. The traps, a rapid insulin crash that drops the osmolality too fast and risks cerebral edema, and bicarbonate for an acidosis he does not have. Right actions, and a slow, deliberate pace. Step 5. Take action, and the sequence carries a warning inside it. One thing comes first, and it is not insulin. One number must be watched and protected before and during that drug. Then insulin can join. Gently. And throughout, one principle governs the speed of everything. Sequence these the way the orders are written. And at each step, ask not only what to do, but how fast you are allowed to do it. Here is the order. First, aggressive isotonic saline, to attack the massive fluid deficit. This is the single most important intervention, and it starts lowering the glucose and osmolality by itself. Second, check the potassium and replace it as it falls, the same principle as ketoacidosis. Third, once fluids are underway and the potassium is adequate, start a regular insulin infusion, no bolus, to finish bringing the glucose down. And fourth, correct slowly, adding dextrose as the glucose approaches 250 to 300, and treat the precipitant. Fluids, potassium, insulin, and a gradual pace. Above all, do not crash the sugar. A too fast fall in osmolality can swell the brain. Step 6. Evaluate. You have poured in fluids, protected the potassium, started a gentle insulin infusion. Now close the loop, and in this condition the best bedside monitor is the patient himself. So reassess. Is his mental status improving? Is he waking up? Because clearing confusion means a falling osmolality. Is the glucose coming down at a safe, gradual rate and not too fast? And have you found and begun treating whatever set this off? Ask, is he waking up? And is the correction slow enough to be safe? Here is the reassessment. The good. His mental status is clearing. He is more alert, tracking, answering, which tells you the osmolality is coming down and his brain is recovering. His glucose has fallen from 1080 towards 620, a steady, controlled decline, not a crash. And the chest film has revealed a pneumonia, the precipitant, now being treated with antibiotics. But the caution stays front of mind. If that glucose or osmolality were dropping too quickly, you would slow the correction, because a rapid shift can pull water into the brain and cause cerebral edema. So keep the fluids and insulin measured, keep replacing potassium, keep treating the infection, and let him come back slowly. In the hyperosmolar state, patience is part of the treatment. Let's tie the case together. Your cues: a glucose of 1080 with an osmolality of 372, blood dangerously concentrated, but with negative ketones and a near normal pH, telling you this is the hyperosmolar state and not ketoacidosis, along with profound confusion and the signs of a massive fluid deficit. Your action: treat it as a fluid emergency first. Aggressive isotonic saline, protect and replace the potassium, add insulin only after fluids are underway and never as a crash bolus. Correct the glucose and osmolality gradually, and find and treat the precipitant. And the outcomes you are steering toward: the volume deficit replaced, the osmolality corrected slowly, the mental status recovering, and the trigger treated. Recognize, analyze, prioritize, generate, act, evaluate. It looked like a sugar emergency, it was a fluid emergency, and slow was safe. Now, the next patient. A young woman with Graves' disease, and she is burning up. A temperature of 40.1, her heart galloping at 165 in atrial fibrillation, agitated and confused, all of it coming on after an infection. Her thyroid is in overdrive, but here is the thing that catches people. It is not the thyroid hormone level that will kill her in the next hour. It is the fever and the racing, chaotic rhythm. Treat the number, and you may lose her. Treat the storm, and you save her. 6 decisions. That is case 207.